Okay, we're starting again.
Great. So yeah, I would say if we're on a chronic PG, those are some things to look after too, for electrolytes and stuff. Okay, tetralogy of Fallot. So we have 3 things that are wrong in this heart defect. First is we have a nice big hole, a VSD. We have a aortic valve that overrides the VSD, so the valve's not that great neither. And we also have a stenosed or tight pulmonary valve. Okay, so tetralogies can come in different severities. Some of them are ductal dependent if they're severe, and when they're going to be severe is when we've hardly have any flow to the PAs. Okay, so you're going to need the duct to be open so that they can have proper circulation. But for the most part, tetralogies can go just like a VSD or a canal. They can wait for a good 6 months before they get repaired. Okay. If the baby is ductal dependent for the tetralogy of Fallot, and they're too small to actually do a complete repair, what they'll do is they'll do a BT shunt is basically what it's called. So they take a little Gore-Tex graft and they basically sew it on. You can see from the aorta there to the pulmonary artery. Okay, so that acts as the PDA, so we don't have to try and keep that PDA open. But these shunts don't last very long. They don't grow with the baby. So we only like to keep them in and around for a few months, and then after that, we need to actually do the repair on the heart. Okay. We used to, way back in the day, have tetralogies have a 2-stage repair. You probably remember this, Dave. And we would send them to Montreal to do tetralogy repairs, and we'd always send them for the shunt, then they come back, and then we'd send them again a few months later to actually get the repair so that they're a bit bigger. But then now and the way techniques and everything are going, we're actually doing full repairs. Now we're hardly ever doing the shunts unless they're a really bad Tet that is ductal dependent, that is too small. We will still do a shunt, but it's not very often that we do that anymore. So they'll be complete repairs. And in some of our other heart defects we'll go over, they do those shunts as well for hypoplastic hearts. So I put BT, and then there's a SANO Shunt as well. So what they're doing now is an RV to PA conduit instead of having the BT shunt, and it's placed on the outside of the heart. So that it could be either, that's why it's called SANO, so it could be either one of those 2 different types of shunts. Okay. So we need to know our baseline sats for kids that have these shunts, okay? Because if sudden decreases in saturations with extreme irritability, we have to consider that the shunt may be obstructed. We may need an urgent echo to see if there's patency or flow through that shunt. In these kids, we want to avoid dehydration. So if they're having a viral illness or a GI illness, we want to make sure that they're adequately hydrated. Special care with vomiting and diarrhea. And these SANO shunts we always watch when they're in their car seats, because the straps can compress and push down on the chest where the shunt is actually placed on the outside of the heart. And then we don't encourage tummy time for those.
A bulge?
No.
Okay.
No, you cannot. And you would think with closing the breastbone, they would provide some protection, but they never want to be too cautious with that, right? Because that's their only way they're getting their blood flow, so you wouldn't want it to be compressed in any way. So for a tetralogy complete repair, basically what they do is they sew a patch on the VSD, they fix the valve, and then they open up the PA. And then they're completely repaired. The one thing that we watch out for tetralogy of Fallots later on in life is their PAs. Usually they start to depending on where they've made the opening more, can actually start to narrow again. So we're always looking at their PA flows to see if they may have some stenosis there afterwards.
So they just get routine echoes?
Yeah, routine echoes. Sometimes if we have to, we can do catheterization to balloon the PAs to make them bigger. We can put stents in there to keep it open as well. So yeah. But otherwise, they're usually fixed. But then as well with these ones have a risk of having the electrical conduction through the AV node where they sew the patch, because sometimes you'll have to have a pacemaker for heart block with these ones as well. So if we've got a baby that's unrepaired TET, they do run the risk of having a TET spell or hypercyanotic spell. So where the pulmonary valve is, where it's narrowed, it depends on how tight that area is, and it's something that we watch for a lot with our babies that are at home. We always make sure that we are getting their SATs checked once a week. Once we start to see that their oxygen's starting to get a little bit lower and lower, we look at trying to treat with some pranolol. It actually loosens the muscle area around the obstruction. So that helps with potentially keeping them from having a TET spell. Doesn't necessarily work all the time, but so physiology part of it, you have the right ventricular outflow tract is where it's going to be tight or obstructed. You're going to have decreased pulmonary blood flow when they're in these TET spells. Okay, you're going to have a increased right to left shunt. You're going to have profound cyanosis, and you're going to have hypoxia. So it's basically that valve or that area is spasmed off, okay, and at that you're going to have these immediate effects, okay. Symptoms are going to be increased cyanosis or change in color, pale or gray, increased irritability, increased respiratory rate or deep respirations, sweating, they're very inconsolable, and sometimes they have decreased LOC, and death can happen if untreated. So when we send our families home with tetralogy kids, we do a lot of education on recognizing a TET spell and also showing techniques to try and get them out of a TET spell. So managing a TET spell, basically recognizing the early signs is the goal, basically to treat the spell immediately. We do comfort techniques because they're super irritable, and the more they're upset, the more that spasm is going to happen right in that area. So we teach the families to do either laying them on the bed and knee to chest, okay, or to have them with their knees up to their chest when they're holding them to comfort them as well. And I just sent out one of my TET families to get repaired, and it's funny how her SATs have, progressively gotten lower and lower. We started propranolol. You kind of see that she's getting a little more dusky, and she really likes sitting with mom with her knees to chest up on her. So they start to want that position in order to help them too. So if it's in the hospital, obviously setting when there's oxygen, we want to apply O2 in a non-threatening manner, okay, and not blast it, right, because we don't want more of the shunt going back and forth, but it just also helps to get them out of that spell. In more extreme circumstances, we may need to do a fluid bolus, okay, and then of course sedation is key with these kids. If they're in quite the spell, we need to actually relax them, so morphine, ketamine, to relax that area. Phenylephrine if we need to increase the blood pressure because of the output is going to be poor. Or an esmolol infusion. We want to intubate, ventilate with 100% O2, and then any bicarb to correct the acidosis.
So from a transplant point of view, I don't think we escort a lot of these kids routine.
We haven't had a really...
No.
bad. Like
Yeah.
the last one I ever remember, it was quite a long time ago,
Yeah.
and they need. She was super,
Yeah.
like she was paralyzed, intubated,
Yeah.
ventilated, and she was still not
Yeah.
doing well.
Yeah, so this is stuff that would all be done in the ICU before you go, but you certainly want to discuss with the medical control. If something happens in the plane, have a plan in place with specific medications and actions to give. And then if in the plane you're not getting results, you call back on the plane has a satellite phone, get hold of medical control and talk it through with them in the plane. But you should have the plan in place before you leave the hospital. What to do if your kid's intubated, ventilated, paralyzed, and has a Tet spell while paralyzed. Right.
Yeah. They need to be paralyzed so they don't
Yeah.
do the
Yeah.
Tet
Yeah.
spells. Yeah. Yeah. Yeah, like I said, in my years, I've only seen one really, really bad one.
Yeah.
Yeah. Okay, another scenario. So we have 1 month old with cyanosis. Is brought in because of 30-minute history of extreme cyanosis and irritability. Is noted to have asymptomatic murmur by the primary physician at birth. Has had history of similar milder episodes over the past few weeks. Heart rate's 170, respiratory rate 70, and the stats are 60. It's crying inconsolably and has a high-pitched murmur. Diagnosis. Tet spell. So again, management, just what we went over as well. What we teach the families is at home is to try and do those techniques, and then it's always a 911 call if any loss of consciousness or they're not able, because they really at that point need to have more medical.
Is the knee to chest just like a comfort position, or is it
Okay,
actually?
no.
It actually it pushes, I think, that area open.
It
Yeah.
helps with the opening of
Yeah.
the plumbing. In the event that we get a call from, let's say, like let's say we have a known Tet up in Thompson, and we get a call. Do we want to put cardiology on the initial call with us to help with management?
I can't see why wouldn't you not, right? I know.
Because usually we would just call our PICU attending.
Yeah.
But you could suggest putting cardiology on the phone.
You could, if it's a known, right?
Yeah.
Yeah.
Because then this would be known to you guys. And,
Mm-hmm.
the history
Yeah.
would be.
Depending on the cardiologist that's on call, they may or
Exactly.
may not know,
Maybe
but
not.
but if they
But-
know it's a TET and they know, like, they'll ask the certain questions and what you did and didn't do and what needs to be done. Yeah.
Do they ever go like undiagnosed at birth and then are discovered?
Yeah.
Like after.
Yeah, like we can have pink. We call them pink TETs. So we like those ones, right? The PDA is closed, and their SATs are still normal. Yes, I mean you hopefully hear a murmur with someone, right?
Yeah.
But
So you will always hear a murmur. Always.
with these, yeah.
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 Okay.
And some things are missed, yeah, like we've had 14-year-olds undiagnosed coarctation of the aorta, right?
Well, I have one of
Obviously,
those in PICU, like
yeah.
years and years and years
yeah,
and years. People with
obviously
PICU.
not gonna be, obviously hasn't had a problem, but after all those years, right?
Yeah.
Yeah. Okay, transposition of the great artery. Most common cause of cyanotic congenital heart defect in the neonatal period. Usually presents with no murmur. Dun, dun, dun. The chest x-ray, if you did one, it looks like an egg on a string for the heart. And we need to intubate and ventilate right away and correct any acidosis. So this is what a transposition of the great arteries looks like. So basically, your great arteries are switched, okay? And as you can see, we've got a PFO, which is causing some mixing, but we also need to have the PDA. And then what we really need to do is make sure that we keep that ASD open and big. So usually do a balloon septostomy. You can't do that when you're picking a kid up, but you're going to start the PGs, right? And that's what a balloon septostomy looks like, and it can be done in ICU at the bedside. Cardiologists come with the echo, and they guide it through, usually the umbilicus.
Mhm.
Yeah. And if anyone's ever seen it, it looks absolutely barbaric.
Mm.
They basically take that, blow up the balloon, and they pull, and the whole baby
The kid
moves.
just jumps off the bed.
Yeah. So you want to keep that ASD or PFO open. You want to make it as big as possible because that's helping with the mixing of the blood.
I don't know if I've seen this. Do serial dilation, like balloons, like they'll inflate it and then a bigger and then, or is it just one big yank?
Usually it's
doesn't
just one
stay
big
in.
wing. No.
That they just put it in
Yeah.
and just
Yeah,
to
they put the
make it
catheter
bigger
in, and
pull
then the balloon is attached to it, and they add saline in there,
out. Okay.
and the balloon expands right under echo. We can see where we
Yeah.
are, and then basically
Just
you just
rip the
yank.
septum open.
Yeah,
Okay.
we're wanting to create the hole.
Mhm.
Yeah, yeah. And no, usually it's just
Yeah.
and yeah,
I've only ever seen it.
yeah. Usually it's one
One
big
big yank.
yank, and then yeah.
But you may try several times though.
Mhm. Yeah, yeah. You have to make sure that's
Whatever's
big enough.
Not skin, but whatever that membrane
The
is,
tissue, yeah.
like it's not falling off, it's just opening. So
Just
it's not
opening, yeah.
going
Like the
in.
PFO is already there.
Yeah.
Obviously, to get the catheter
Yeah.
across, you need to go through the PFO, but we want to make it bigger so that
Mhm.
it doesn't close. Because you know, PFOs, as do PDAs, usually
Yeah.
naturally close right after birth. So we need that PFO to be an ASD basically, and
Yeah.
just have as big as a hole as we can. So that's what it looks like after the septostomy. So you can see a little bit better color changes on there, and your SATs are going to improve as well. But this child will need to go for surgery to be corrected right away. And then surgically after, what they do to repair is they switch it, basically cut them and then switch it. And then these ones are really good afterwards. You don't need much, wouldn't really need much in the future for any surgical repairs afterwards. The one thing that we do watch out for transposition kids is their coronary arteries are actually, or opposite, they're switched, they plug them back into their receptacle parts. So we always make sure that we look in regards to any coronary artery problems with these kids. Okay.
Are they always switched?
What's that?
Are they always switched?
So they're not going in the right ones. Once we have to switch the vessels, then we have to plug them into their right vessel, where they're supposed to be. Yeah. So general principles. When blood flow to the lungs is reduced, blood must enter the lungs somehow. So they're ductal dependent. As the ductus closes, systemic blood flow is okay, but remember that the blood returning to the left side of the heart contains less oxygen. Okay, so we're mixing. In a TGA, the aorta ejects deoxygenated blood to the systemic circulation, so we need that mixing in order for a baby to survive. Okay. Oh, another one. Oh wait, another case. So we have a Dusky 3-day-old, normal pregnancy, full-term delivery, unremarkable newborn exam at 24 hours. Concern over the past few hours, RE change in color. So our triage assessment, heart rate's tachy, well, not so much tachy, but 150 for a baby. Respiratory rate's 50, blood pressure's fine, SATs are 70. No murmur and no failure. Okay, this is probably what you might go right up to Thompson and find, okay? Your pH is 7.33, your CO2 is 40, your bicarb's 22, and you have a lactate of 2, which I'm assuming is not good, right?
Not horrible.
Not horrible, but. So, what's our next step? I'm going to try and do the hyperoxic test, okay? Is there a change in the SATs with O2? No change. Most likely diagnosis, cyanotic heart disease until excluded. Okay, next step, PGs. So some other lesions with decreased pulmonary blood flow can include tricuspid atresia, an unbalanced single ventricle physiology, which is like a double inlet left ventricle. So this is what a tricuspid atresia with a VSD looks like, which is good. It has the VSD, so we're helping, right? So we have an absent or blocked tricuspid valve. Okay, so you can see where it's narrowed there. So these are obstruction to now systemic blood flow. We're all good so far? Okay. Is it getting too dry? Okay. Okay, so now we're looking at the other end, our systemic end now. So we have aortic stenosis, coarctation of the aorta, interrupted aortic arch, and hypoplastic left heart syndrome. The extent of obstruction will determine the extent of the symptoms. So hallmark is the inability of blood to reach the body, causing signs and symptoms of decreased cardiac output. Okay? You're going to have decreased pulses and possible differences in the upper and lower extremities. You're going to have poor color, decreased urinary output, and evidence of decreased blood flow to gut, which can cause neck, right, in our neonates, which you guys see a lot of. In the worst case scenario, blood cannot move past the obstruction, causing it to back up into the left atrium and then to the lungs, causing heart failure symptoms and pulmonary edema. So symptoms of heart failure can be coupled with symptoms of poor cardiac output too. Okay. So some long-term effects on the LV is that you're going to have greater pressure, it's going to get hypertrophic, and you're going to have poor function. So some underlying concepts. Systemic blood flow may be reduced because of anatomic narrowing or severe obstruction at the aortic or mitral valve level. Okay. Some severe lesions are dependent on a right to left ductal shunt, and they may lead to some cyanosis when the PDA is maintained with PGs. Okay? So you're going to see some mixing with that. In some cases, blood flow to the brain and coronary circulation is dependent on retrograde flow. So here's one that's quite common, aortic stenosis. It could be severe, or it could be not so bad. Okay, we could be going to the cath lab to do it, or we may need to go to the operating room to fix it. So basically, you can see the valve is tighter or narrowed, and that's causing backup and causing the LV to be thick. Okay, and then it's not going to squeeze, it's going to have poor function. So like I said earlier, we can fix this sometimes depending on the severity of it. With a cardiac catheterization and a balloon dilatation. So same as trying to make that ASD with a septostomy, we actually balloon or stretch that valve open in the cath lab. So it doesn't have to be open heart
So
surgery.
you just inflate the balloon and then
Yeah.
dilate it and then
Yeah.
hopefully dilates that.
Yeah,
Okay.
you usually do it a few times as well, and the trick is to try and not over dilate it, where you're going to cause the valve to be leaky afterwards, right? Because then it's harder. Then you're going to look at other symptoms that we have to manage.
So the valve will be functioning after we do
It
this?
functions, yeah.
Okay.
Yeah, then the area, the narrowing gets less, obviously, and it might be something that we have to do repetitively down the road in some years too. So we have coarctation of the aorta. Okay, there's interrupted arch, there's a complete coarc, there's coarcs depending on where it's coming off the head and neck vessels. Okay. And like I said earlier, the interrupted arch, you see, there's no continuation of the arch. Not a good thing. And then we have hypoplastic left heart syndrome, where we have a few things wrong. We have underdeveloped or hypoplastic left ventricle. The mitral valve is included in this. The aortic valve is not well as well, and the ascending aorta is not good. So these kids actually have to go through a 3-stage surgical repair throughout their life to actually correct this. And it's usually finished correcting at around 3 to 5 years of age. Okay, but we start off with the first stage doing that BT shunt or the conduit, the RV to PA SANO conduit. So if we have a kid that's born with hypoplastic left heart syndrome, and this is one that needs to go out right away, it's going to need your PGs, we want to improve systemic blood flow, and we want to reverse any metabolic acidosis, and we want to provide respiratory support and assess for any secondary system damage. Okay? How are we going to do this? Well, we're going to intubate and ventilate, which reduces the work of breathing and strain on the heart. We want to start the PGs so that we have perfusion. We want to avoid hyperoxia and hypocarbia. We want to maintain IV infusions, potentially some inotropic support, which can provide function of the heart, diuretics if we need, and then we're going to monitor arm and leg pressures to avoid any differences. Another case study, we have another Dusky 3-day-old. This almost seems like the last one that we did. This one's heart rate's 180, respiratory rate's 80, that's quite high. BP's not really good at all. Okay, so that's another thing too when we're looking at these left-sided heart defects. If there's any obstructions, your BPs are going to be a lot different than if it was the right-sided heart defects, right? You should have normal blood pressures in the right-sided, left-sided because we're having obstruction to the systemic. So that's another key, right? It's like, BP, right? It's not really good. SATs are 70. You're going to hear a gallop. You're going to have a big liver. The pulses are not going to be very good peripherally if you're feeling for the groin. You're going to have a pH of 6.9, CO2 is 35, bicarb of 6, and lactate of 15. Those aren't good numbers, right, Dave? No. Yeah.
These guys are the big expert, but those are bad numbers.
So basically we have a hypoplastic left heart. Do we even really see... The thing is nowadays for fetal ultrasounds, thank goodness,
Yeah.
We're actually being able to know more about these heart defects before. We don't get
Catch
very
over-
many
I think we
surprises.
catch well over 90% of them.
Yeah, yeah. It depends on if the
Yeah.
mums are going for their assessments and
right.
stuff too. If they had not very much prenatal care, I mean, you can't.
You can't predict that.
You can't.
And you can't.
But I think over the years now we actually know more of the diagnosis prior, so we
Yeah.
don't get these
I
surprises.
recall we used to go for more in the community than
Yeah.
we do now.
But not so much for hypoplast lately.
No, not for,
hey?
oh sorry, not for hyperplast,
Yeah.
no.
So I won't
Probably
suspect that you'd be
PPRs.
blind going
Yeah.
somewhere and having a hypoplast.
Yeah.
TGA, yeah,
TGAs.
I think is pretty common.
TAPBRs.
Mhm.
Or T, I guess it's D's now, drainage.
Whichever, yeah.
Um,
Stenosis,
Undiag-
any aortic
yeah.
stenosis, pulmonary
like aortic
stenosis.
polystenosis, undiagnosed.
Yeah. But very, yeah, not so much anymore. So initial management, we're going to intubate and ventilate, start our PGs, and any inotropic support if we need of the poor function, and correct any acidosis. So here's the stages of how we would fix the hypoplastic heart. So there's the one with the BT shunt. That would be the initial, this is the first operation the baby would have within days, okay, of being born. So because we're not keeping the PDA open, we're going to make its own PDA with the BT shunt. We're going to reconstruct the aorta, and then we're going to keep an ASD, or if there wasn't the PFO there or whatever, we'll make sure that it's removes. So we have some shunt like flow back and forth. And then, and the shunt. So it's a few things. It's a big surgery for a brand new baby, right? This one, even though it looks like they didn't do too much, it's a huge surgery.
So
And then,
now, sorry.
no, that's okay.
Now your right ventricle is going to be your main pumping
Yeah.
for both pulmonary and systemic.
because the left side's small, underdeveloped. We're going to use the right side to actually be the main pumping chamber, and that's our goal through this 3 stages of the surgery. So this is the initial one. So when these babies come back, their main issue is feeding, because they never learned how to eat right out of birth. We intubated, ventilated them, went through surgery and everything. So a good chunk of these babies, when they come back, have to be back to hospital, and feeding is the main issue. Once they're discharged from hospital, we teach the families on signs and symptoms on what to watch out for that shunt. That's a huge thing. So we're always monitoring their SATs, going through the whole thing about making sure they don't get dry, any viral infections, those types of things, and then obviously thriving, right, gaining weight, feeding, all those types of things, until we actually look at going through their next stage of surgery. They're pretty precarious in this stage before they get their next procedure. So these might be some you may be transferring to Edmonton on a urgent basis, because the shunt, if it obstructs, then that's their only way of their blood flow. Okay. So I kind of went over that already. Sorry. Tips for managing kids post Norwood. Kids are most tenuous between the stages 1 and 2. We treat them seriously, even when they are well. It's always important to get oxygen sats on these kids, because it's going to tell us a lot of information. If a kid presents, we usually try and get a gas to see if there's any base deficit and lactate. And sats as low as 70 in these kids are normal. Okay, so 70 is okay. They might be a little bit higher. They might be 75-ish. But under 70 persistently is more of an issue. Okay, we're thinking there might be something going on. We don't want to hyperperfuse these kids. We don't want them greater than 85. So if they come in with some viral thing, of course everyone wants to throw oxygen on them, but this one as well, causing systemic steal. Okay, and that's not good in these kids. So O2 is something that we watch for these kids as well. We always teach the family that blue and warm is good, because they're not going to be pink, right? Pink and cool is not good. And we usually, if we don't give them a home sat monitor, we usually get them to come to our clinic once a week for sure to get their SATs checked. But they also supposed to let us know that if their SATs are less than 70 and they're persistently blue, that they need to let us know. Like I said earlier, the hydration is very important to maintain balance, and then weight gain as well is something that we watch out for. And it's very interesting, because this actually, I've seen it lots of times. Once, if the shunt's not working, even though it's a baby, they get this worried look on their face. They frown, and it's very interesting when the shunt is obstructing. Yeah. Okay, so the second stage, and in between each stage, we always do a heart catheterization so that we can monitor the pressures in the lungs to see how they are. If the pressure in the lungs are too high, we might not be able to do the Glenn right away, and this is called the Glenn procedure. So basically, remember they had the little tube, the shunt, the BT shunt. They remove that, and they actually connect the SVC right up to the right pulmonary artery. So that's the shunt, okay? So usually at this stage, they're a little more stable. We can relax a little bit more with these kids because we have permanent flow, okay? Going directly, all the blood flow from the head's going straight to the lungs, okay? We don't have to worry about that kinking off. The only thing that we do need to worry about with the Glens is if that area starts to get narrowed or obstructed as well, because sometimes that can happen, they can get a SVC syndrome. So their head and neck get really puffy and big. the kids will actually, because they're still too young to talk at this age, will actually like have headaches and they'll bang their head on things and they'll be very irritable. So basically all the pressure is pulling up in that area if it gets obstructed or narrowed. Okay. So the O2 sats are variable with the littlest change, such as crying. So we expect this. So if you put them on a sat monitor, everyone's going to have normal sats for a long period of time. With Glens, and even with BT shunts too, you'll see that they'll go up and down, up and down, up and down, okay? But as long as they're not consistently staying low, then we're okay. So if you're ever to watch them with an O2 sat monitor, you will see the variation of their sats going up and down. We also want to use O2 cautiously with this Glen as well, because their circulations are still not separate yet. And then I just talked to you about the SVC syndrome as well. And then, well, with most cardiac kids, right, cyanotic heart defects, you're going to use filters in your IVs. So remember, this procedure is just used for, or is used for other single ventricle physiology as well. They're usually less fragile after this stage, and any respiratory disease process can occur in decreased O2 sats, increased PVR, decreased alveolar ventilation, and interpulmonary shunting. These kiddos, usually their sats after the Glen are probably in 80s, mid 80s, okay? That would be normal for a Glen sat, okay? And then the last procedure, then we're going to do another heart cath to make sure everything is still going good before we actually do the Fontan procedures, the last procedure. So we've hooked up, connected top half of the body from the head straight to the lungs, and now we're going to do that as well from the bottom half of the body. We're going to put it straight up to the lungs. Okay, so that's passive flow. There's no pump actually pumping the blood to the lungs. Okay, it's all passive flow. And then basically we've made the right ventricle into the main pumping chamber. So it bypasses the whole left side because the left side is not functioning. Okay, does everybody understand that? Make sense? Okay. And then what they usually do, for the most part, is we actually, where it says intra-atrial patch, direct flow from the IVC to the PA, they usually poke a hole in between there, and it's basically called, it's like a pop-off valve. It's a Fontan fenestration is what they say. And what that does is it's helping the lungs get used to having all this extra flow going to them, right? And they usually put a little hole in there so that if the pressures in the lungs get too high, that pop-off valve basically helps get rid of some of that extra pressure. It goes through, the blood flow can go back through that hole. We usually keep them with a fenestration probably for a good year and keep it open. And then later on, if we're feeling everything is looking pretty good, we actually can do another heart catheterization and plug that hole with a device. So if they have a Fontan fenestration, if that pop-off valve is still there, their sats are probably going to be around mid 80s to maybe 90. Okay, so you're getting a little more and more pinker. Okay, once they actually close off that hole, you can expect the sats to go almost all the way up to 100%. Okay. Keeping in mind with these kids, they're still going to be quite fragile if they ever get sick, right, after even their complete repair, because they only have one side of the heart that's actually functioning properly.
What does the heart sound like when you listen to it?
You probably will hear some flow murmurs. Yeah. I don't think it sounds. You'll hear murmurs, right, with flow for sure, because everything is. Yeah. You can come to the clinic and listen to the kids. Yeah. Does that make sense? Yeah. So now for tips of post-Fontan procedure, remember now that pulmonary and systemic circulations are now separate, okay? So they should now be pink with SATs greater than 90% if their Fontan fenestration is closed. Blood flow is passive to the lungs, so we're going to use IV filters. And then patients should have rhythm checked if they present with any concerning symptoms. They also are known for more heart arrhythmias as well because of all the different ways they're having to reroute all the blood and everything. And then we're also going to look at long-term complications with decreased heart function, clots, stroke, arrhythmias, and PLE. So that's protein-losing enteropathy, and that's sometimes where their albumin gets, like their Fontan is basically failing, so the liver gets big, their albumin gets displaced, and we have to look at trying to treat that. And if it gets to the most worst extent, basically the next thing is heart transplant for these kids. These Fontan procedures have been going on for a while, but not very, very long, right? So these are still new surgeries, but we're seeing our kids surviving way into adulthood now. So
And can they do, play sports?
they can. They're not gonna be athletic wizards by any means, but we always want them to do gym class and do sports and stuff. They might not be able to keep up as well as a child with a normal heart, but they definitely.
But for safety wise, it's
They can do. We
fine.
don't want them competitive sports, those beep tests, those things. They're not going to be able to do those anyways. They just don't have enough reserve. So we always have little care plans for these kids for in the school, and what activities they should or shouldn't do. But for the most part, yeah. They,
So what would be the oldest child who's had Fontan now? Like how long has it been going on?
I'd say they'd be at least in their 40s, I would assume. Yeah, it hasn't been going on like this. These procedures haven't been going that many years, but yeah. But now they're actually surviving. Yeah.
And how old are they between the first and third?
Procedures?
Yeah.
Oh, okay, sorry, yeah. So the first one is days. The second one is 3 months. We're gonna do the Glen, and then after the Glen, we usually wait till about 3 years of age. Yeah. So usually around 3 to 5 is kind of where everything is kind of done. If they have a fenestration that needs to be closed as well. When they have the fenestration that's still open, we have them on Coumadin, so that we decrease the likelihood of blood clots going through. So they have to be on Coumadin until we close that fenestration. So yeah, they have to do blood testing for the Coumadin and stuff.
One question, I remember as a kid we had to go to Dauphin, DePauw. Do they get pleural effusions very often?
Post?
Mm-hmm.
Yeah, post.
Back at home?
Usually you see it right after surgery.
Well, actually I know what it was. It was a chylothorax.
Oh, kylos. Kylos are a huge complication of cardiac surgery. They're very hard to treat sometimes, and if we'll see like failing Fontans, once they do their Fontan, if it's not a good repair, they're not doing well with their Fontan, they'll have a lot of chylothorax that they need to be treated. Some are very.
And this kid was in the community, so.
Yeah.
Okay, just remember that still on our minds.
Yeah, well, there's always potentials. Yeah, and pericardial effusions are a common complication after heart surgery as well. Okay, here's another one. Infant with heart failure, 3-month-old, brought to emerge because of respiratory distress, irritability, and poor feeding. It's progressive over the last 24 hours, and the triage assessment is heart rate's 280. Respiratory rate's 80, blood pressure is 60/40. There's a gallop rhythm. What's our gallop?
280 SVT.
When they see, remember how we were saying before with even putting your hand on, you could actually thrill, and then you can actually, a gallop, you could actually It's like a horse rating. But when the heart rate is,
Stethoscope, just.
you can, yeah,
Oh.
but usually when a heart rate is 280 like that, yeah, you're just gonna hear that, right? You're never gonna be able to count it, but when you like listen, yeah. And they have normal pulses. So we see that our blood pressure's okay, right? It's okay. It's not bad. We see that we have normal pulses, okay? We're looking at our heart rate now, which is really, really high. We know that babies have fast heart rates to begin with, but not that heart rate, not that fast. And is having a hard time breathing too, is really quite tachypnic, okay? And the liver is 4, okay? So that means it's bigger. And our cap refill is 4 seconds. And we hook them up to a monitor, and this is what we see. I know we're not doing arrhythmias today, but this is another scenario which can show that it looks like they're in heart failure symptoms, okay? But we also have to look at other things too, like the heart rate and the rhythm, okay? So does anybody want to take a guess as to what this might be? You're so smart. Yes, SVT. Okay. So when the heart rhythm is faster than it should be, it's too fast to count, you're seeing that there's symptoms like that. It's not going to be sinus tachycardia because they're already showing that they're in some failure. They've obviously been in this fast heart rhythm for a while. Okay. And basically, we want to actually get them out of that fast rhythm. We can try vasovagal techniques. With babies, we can either take a suction catheter and kind of do some vagal suctioning that might help break that rhythm. Ice to the forehead will try and help as well. But if we're not breaking that rhythm and we're starting to see that our blood pressure is getting lower, we're having signs and symptoms of systemic perfusion that's not good, we know that the baby's not tolerating that fast rhythm. Okay, for the most part, SVT is manageable and tolerable. They can be in it for a long time. But obviously this baby's been in it for quite a while to show you some signs of failure symptoms. Okay, so then we're going to try adenosine. If we had to, we could do an esmolol infusion. And we always want to make sure that we always get an EKG while they're in tachycardia and then afterwards after it breaks. Because it also gives us a lot of information in cardiology too on where we think that actual rhythm is coming from. And post afterwards, obviously we're going to treat with oral antiarrhythmics, and we're going to admit for at least 3 days to make sure that the medication that we're giving them is working and they're not going in and out of SVT. Another scenario, another 3-month-old. With irritability, respiratory distress, poor feeding, and progressing over the last 2 days. We're looking that there's some upper respiratory tract symptoms, a low-grade fever for 1 week, and then our triage assessment, heart rate's 190, respiratory rate's 80, and BP's 50 on 30. We hear a gallop rhythm, and we have decreased pulses. And our liver is about 4 centimeters. And our cap refill is 6 seconds. That doesn't sound too good. Oh, and we have increased troponin. So we did some blood work. And then we have an x-ray. What does the heart look like to you guys? It's big. Pretty much takes up the whole space, right? That's a big heart. Okay. We do an EKG. We see some ventricular couplets and some short runs. Okay, so we're having a wide complex, and we're having a couple of those beats in a row. Not normally what we want to see. Okay. For our diagnosis, we have myocarditis, and I know this isn't, but
No,
this
actually,
could,
we've done some
yeah,
myocarditis.
this could
Yeah.
happen right in Thompson or whatever. If you're going to pick up a kid. There's lots of viral myocarditises out there lately, and cardiomyopathies that are coming out of the woodwork from all these crazy viruses, right? So this is another thing that can be what we can think about as well. Their heart might be structurally normal, but they're having all these other things, right? So in extreme circumstances, if they're quite depressed, we're going to intubate and ventilate. If in shock or hypotensive, metabolic acidosis, or increased lactate, we're going to avoid excessive fluid administration. We don't want to volume overload these kids. We want to do a diuretic trial, and then we need to be cautious with inotropes because they could actually start some arrhythmias in these kids. And then obviously we're going to take them to PICU.
Transport, we probably won't be doing a diuretic trial because we don't want to upset that kid's blood pressure while on the plane. But
Yeah.
that's meant to be done in a tertiary care hospital under supervision. So
Yeah.
we would all remember the sins with the cardiac and the lectures that Mary said. Not excessive fluid administration, support the blood pressure, and support the kids' respiratory symptoms.
What's your go-to inotrope?
I'm not sure exactly which one they would use for. That's a good
Is
question.
there one that avoids arrhythmia?
Yeah, because then
more
you
than
want to
another?
right. You want to make sure that there's something. I'm thinking norepi off the top of my head, but I can't remember. I know there is one. Yeah, but then that's one case where you'd be trying to talk with cardiology if you're thinking it's like something like that. They'll give you better. Yeah. Better instructions on which ones to avoid.
Why is the troponin elevated versus other failures?
That's
Is it
the
like
marker
the
for the
actual-
heart.
Correct.
Yeah.
Is it the muscle itself is ischemic?
Not ischemic, no, but it is like with myocarditis,
Part
it's
of
inflammation.
cracks, right? You'll see that.
Yeah. Yeah, you'll see it's like the inflammation of the heart.
Inflammation.
Yeah. Yeah. So, in conclusion, the recognition of pediatric cardiac emergency requires rapid recognition and intervention. Clues to specific diagnosis are often available prior to specialized cardiology investigations, and the history is obviously very important. And we need to start therapy before the cardiologist arrives.
So if you're in Thompson, he's not coming.
No, you're not coming.
So
So you guys are the best eyes and assessment skill seekers, because you're the front line.
thanks.
Done.
Thank you.
You're welcome. Any questions that you guys can think of?